It's great to be with you. It's wonderful, as Maureen says, to be together again in this way and to have this opportunity to be present with all of you here for the first time in far too long. Last week in Region Jönköping, we've talked about Jönköping a bit, IHI strategic partners, 19 health systems from around the world, did something we haven't done in over 2.5 years. We met together. We ate together. We walked together. We even sang karaoke together. Some of you will remember that. We climbed out of the two-dimensional tiles in our computer screens, and we became, once again, three-dimensional human beings. We learned and we pushed, and we set new goals for each other in service of making health and care better for everyone. It was majestic. It was real. And honestly, it was a relief. I have to confess at the beginning of this talk to a bit of imposter syndrome. I meant to give you all a talk about creating the health system of tomorrow, of the future. But so much of my experience as a physician and a public health expert is from a country, the United States, where we struggle to meet our basic health needs and where health still is not yet a human right. And then I come to Jönköping, where leaders have committed themselves to quality and healthcare improvement as a business strategy, not for 1 year, but for 25 years. And where humbly and steadily the system has been achieving breakthrough clinical results, where costs have plummeted, and where you have moved well past the technocratic question of how to make healthcare better to the spiritual and much deeper question of how to achieve a good life. It's humbling to witness. It's breathtaking, if I'm honest. And I'm tempted, on some level, to just yield my time and ask every international participant sitting in the crowd today to find a Swedish colleague and go for a long walk in the beautiful midsummer morning to speak to each other, as we did in Jönköping, about what a good life means to each of us. But I suppose I won't do that, or I can't do that. So perhaps instead a story. During our time in Jönköping, we made some side visits. And no visit to Sweden would be complete, I think, without a trip to the legendary home furnishing store of IKEA. I think I said that right. Here we go. IKEA, or IKEA as we know it elsewhere. We got to go in the back door to see the operations from the inside, see how IKEA stages, how it designs new products and services, and most importantly, how it creates a remarkably consistent culture of continuous innovation and customer engagement that has spread a bit of beautiful Swedish design to kitchens and living rooms in over 60 countries. In the staff room at IKEA, I came across this word written on the walls that has quickly become my favorite Swedish word because it encapsulates so much of what I'm feeling right now at the start of this amazing forum. Tillsammans. Did I get that right? All right. Tillsammans. Translated, tillsammans means together. And below the word, IKEA's legendary founder, Ingvar Kamprad, had this message for all of us. We know that we are at our best when we trust each other, pull in the same direction, and not least have fun together. So as I welcome you here this morning to the IHI BMJ International Forum on Quality in beautiful Gothenburg, let me invite you all to do exactly this. Trust each other, pull in the same direction, and have fun. Tillsammans, together. When I asked my friend Göran Henriks, who you just saw a few minutes ago, for pronunciation coaching yesterday, before I opened my mouth, he knew exactly what word I was going to ask him to teach me. Because this word, tillsammans, and all that it implies, trust, courage, joy, it is an antidote to so many of the challenges in healthcare and in our societies that we see today. Let me explain. It was a Saturday in May. I was at a football match watching my son and his teammates run up and down the pitch trying to figure out how to pass the ball. They're 8, so they're trying to figure out how to pass the ball to each other. It was a beautiful day. There were smells of cut grass and the flowers waking up, not just from the night, but from a winter underground. I was taking pictures with my phone, and it dinged with a text message from Don Berwick, the legendary founder of IHI, and the former head of the Centers for Medicare and Medicaid in the United States. Don, who many of you know, Don and I have worked together for a long time, and he doesn't often text me on the weekends, but his message read, "We have much to do to achieve real healing. See email." So I did as directed. When Don tells you to do something, you do it. I went as directed to my email and found that he had forwarded me a note from a colleague, Dr. Claudia Finkelstein. Claudia is a faculty member at the University of Washington in Seattle. I didn't know Claudia, but I later learned that she had spent a 30-year career in medicine as an internist, a geriatrician, a medical educator, and a wellness administrator. The note that she had written started ominously. Tuesday, at the podium in a small auditorium, I realized my time was up. This was the rest of what she had written. Early on, my work's purpose, meaning, and love were easy to access. The rewards easily outweighed the inevitable stresses of the job. The ability to connect deeply to alleviate suffering in both patients and trainees was more than adequate compensation for the difficulties of the work. I was sure my patients could tell I cared about them and for them. But along the way, something shifted irreversibly. I didn't notice when the indifference started to crowd out the love and joy for my work. But now there is no mistaking it. What had happened? The cause is murky and multifactorial. Some nature, some nurture. The political, societal, and economic changes to how we provide care were definitely a part of it. But increasingly, my inability to address social inequities as the root causes of many of the primary care visits created moral distress and a sense of powerlessness. I felt like I was peddling amlodipine and Prozac to people who needed a proper living wage and an equal playing field in life. It became more and more difficult to believe that I was actually helping people. Over the decades, I deployed many career strategies, Claudia continued, ways to avoid spending half days per week cranking out 15-minute visits in the office. One example I took to teaching students. In addition to feeling on purpose and loving the students, this was paid time out of the clinic. I loved this part of my job until I didn't. Unfortunately, I couldn't square the contradictions. I was teaching the students to take the time to get to know their patients, to get to know their person, write a thorough history, perform an in-depth physical exam. And I knew, meanwhile, that in actual practice, things would be very different. They would instead wind up checking boxes in the electronic record, copying, pasting, and forwarding notes. It felt like a bait and switch, so I stopped. It may be that I have not been up to the task of making things better. It may be that I no longer relish connecting to the individual trainees or my patients. Maybe I have just run out of compassion and steam. The letter ended as abruptly as it had started. And I remember standing there with a shiver running down my spine on that cold spring morning. In medicine, as many of you know, we are trained to look for cries for help. This was a cry for help. And not just from an individual, but from the healing professions as a whole. As I thought about Claudia's letter, I kept coming back to one particular sentence in her note. My inability created moral distress and a sense of powerlessness. And It reminded me of something I'd heard before, just recently. My father has been a small-town community pediatrician in my hometown in New Jersey for over 50 years. The kind of doctor who can't get through a grocery store without running into his patients in every aisle and at every checkout counter. He's resisted calls to retire even as his friends have knocked off to play golf or travel around the world. What will I do with myself? I don't like reading novels, he'd complain to me. But just 2 weeks before I'd read Claudia's note, my dad had called me to tell me he had had it. He was hanging up his stethoscope. His practice had been bought 2 years earlier by a large group practice consortium, and they were finally not happy with his productivity. He was used to deciding how long he could spend with his patients and his trainees. He wanted to counsel his patients and their families on his schedule. He wanted to hear their stories whenever and however they wanted to tell them. They, the administrators, wanted shorter visits and more immunizations. His style of doctoring, how he helped people get healthy, didn't jive with the group practices model, the mental model that they had. And so he, like Claudia, was planning to get out. Back in the 1980s, Andrew Jameton, when describing the pressures on the nursing profession, had helped to frame the distinctions between moral uncertainty, where the moral course of action is not known, moral dilemmas, where a choice is present between two or more ethically justifiable actions, and the concept of moral distress, where nurses were asked to execute actions that went against their morality and their conscience. Many such moments of distress exacted over time would accumulate, and they would result in lasting and potentially permanent moral injuries. In the 1990s, the concept was added to by psychiatrist Jonathan Shea, who described the perpetration of actions that led to unjust results, not as passive happenstances, but as leadership malpractice. Shea suggested that moral distress was caused by injurious actions of leaders. He wrote that moral injury stemmed from the betrayal of what's right in a high-stakes situation by someone who holds power. In other words, moral distress might be the effect, but moral injury was its cause. Reading Claudia's note reminded me of the discussions I had had with my wife, who is a palliative care physician, an infectious disease doctor, and the hospital ethicist in our local town. She's the accomplished one. We used to describe Mira's many roles in the hospital during those early days as the triple whammy. People were dying prematurely and horribly in her hospice units of an infectious disease that presented every one of us with continuous daily ethical conundrums. In those early days of the pandemic, we would talk about the choices she was being asked to force her clinical colleagues into. Impossible decisions about who to give ICU beds to, how to divvy up ventilators, what care should be delayed or permanently put on hold, who should receive the scarce PPE that was available. Ultimately, she too, like Claudia, couldn't square the contradictions. Our leaders, both political and within the hospital, couldn't protect us from these situations, and some of our colleagues paid the ultimate price, while many more were forced to make horrible choices that went against our oaths and obligations to heal. These impossible choices felt new during the pandemic, and yet they were also very familiar. For years, we have been making these kinds of choices in healthcare. Every day in hospitals all over the world, we force mental health patients to wait in emergency departments for days on end. We place our older patients in decaying nursing homes that are understaffed and under-resourced. We allow our unconscious biases to undertreat pain and hemorrhage for our Black and Indigenous mothers. We force our poorest and most vulnerable to travel the longest distances because there is no quality health care in their communities. In the US, healthcare regularly confiscates the funds we set aside to educate our children, care for our elderly, and provide options for our poor. These challenges were not made by the pandemic. They were exacerbated by the pandemic, which proved adept at understanding our vulnerabilities. The virus found where our systems were not prepared or coordinated, and it exploited those weaknesses. It understood that we had underinvested in poor people's health. It knew that we had built a house of cards around the care of older adults. These weaknesses have been chronicled, as all of you know, by many around the world, and versions of this story have played out on every continent. But what has been a bit less well understood was that the virus pried its insidious and dangerous fingers between healthcare systems and us, the caregivers, showing us how the process of caring itself has been crumbling for years without us even really seeing it, and finally taking some of us, like Claudia, down with it. There's a lot written about burnout these days. Global surveys suggest that 1 in 3 clinicians are considering leaving their jobs within the next 2 years, with as many as half leaving the health workforce entirely. I was comforted to learn yesterday at breakfast here in the towers that the nursing workforce here in Sweden isn't yet in this kind of crisis. But in my home country, in the US, 1 in 5 healthcare workers has already quit their jobs. And 2 in 5 nurses intend to leave the workforce in the next year. Seeing this, organizations have invested in wellness programs and efforts to bolster resilience in our workers. I know this is happening here in Europe because all through the pandemic, colleagues across the continent, many in this room, would share stories and photos of these well-intentioned efforts pushing yoga, personal restoration, exercise schemes, and sometimes plying staff with food and chocolate bunnies. But the pressure on the system and our staff was too great, and these fixes too superficial. What's more, these efforts fundamentally missed the diagnosis. In a survey of over 5,000 US physicians in 2020, Colin West and colleagues from the Mayo Clinic found that physicians and nurses don't lack resilience. In fact, in general, they were more resilient than the overall public. And yet, despite that resilience, our colleagues were and are experiencing burnout at unprecedented levels. What is going on? The problem isn't the resilience of our healthcare workers. The problem is far more fundamental than that. Dr. Wendy Dean, a psychiatrist and surgeon in Boston, worked for many years with Army veterans and survivors of conflict zones. And she recently founded an organization called Fix Moral Injury, which focuses on helping healthcare workers worldwide. Wendy says, there are a lot of roads that lead to burnout, but the highway is moral injury. It's in the very structure of our health systems. In a recent conversation, Wendy said to me, training individual resilience assumes individual frailty, but moral injury is a systems problem. We need to fix the whole system. To use an analogy, Wendy said, we have a healthcare workforce full of high-performance Lamborghinis. You may like this comparison. We ask them to go out on roads full of potholes and fallen trees. To let the Lamborghinis perform to their full potential, we need to fix the potholes and clear the trees. So how do we do that? How do we start to fix the potholes and remove the fallen trees? I focused this talk about the future of healthcare, about creating tomorrow today, with a focus on us, the staff of our health systems, because it's my view that the only constituency capable of changing healthcare is us. We uniquely understand the daily challenges. We alone know the system is riddled with potholes and fallen trees, and only we can square the contradictions and end the moral injury that Claudia was suffering. And we cannot do this task alone. as I've learned here in Sweden. We must do it tillsammans, together. As author Alice Walker once wrote, "We are the ones we have been waiting for." In so many health systems, we have misunderstood the production of better health as a series of technology-enabled transactions. We faithfully deliver the transaction, we make the diagnosis, provide the tablets or the procedures, measure the result, and then move on to the next patient. But as all of you know, this is hardly the essence of healing. And it is this fundamental misunderstanding that is at the heart of every major pothole and fallen tree that blocks our path to creating more human health. Now, as we consider what will the future of our healthcare system be as we emerge from the incalculable global loss that we've suffered, we must not only fix our emergency rooms and how we access and coordinate care, but we have to do something far more challenging, and that is to heal ourselves. Heal ourselves, heal our systems. So where do we start? I say we start with why many of us in healthcare got into it in the first place. A desire to be in a healing relationship with our patients, our families, and our communities. 50 years ago, the health economist Victor Fuchs noted that there are two kinds of enterprises: those that produce goods, products, and consumables, and those that produce services, interactions, and experiences. In the former, control of how we create value is almost entirely in the hands of the producer. Add more bells and whistles that people want to a product, and you can charge more for it. Make the Volvo, I know I'm in Gothenburg, so make the Volvo go faster, or use less gas, or drive itself, and you can charge more for it. But value in a service or in an experience is not created by the producer alone. It is co-produced with the participant, the buyer, and the user. In other words, value in service industries is born of the interaction. It is the interaction itself that is the product, and the interaction is driven by two or more people in a relationship. And those relationships, in turn, depend on trust. As I began to study this, I learned about a whole field of work led by sociologists, psychologists, business leaders who have been studying trust in organizations and societies for many years. I found the work of Francis Frey, a Harvard Business School professor who worked for Uber a few years ago when the headlines were full of how Uber's toxic work culture, riddled with sexism and harassment, was failing drivers, the engineers, and its customers. Uber had a massive trust problem, and when they were in real trouble, they called Francis for help. Frey's model of trust is composed of three essential components: empathy, logic, and authenticity. If you believe that my empathy is directed towards you, you are more likely to trust me. If you believe my reasoning makes logical sense, you are more likely to trust me. And if you believe that I am being authentic, then you are much more likely to trust me. These three things, empathy, logic, and authenticity, are both where trust begins and where it can break down. But how exactly do you actually practice these things? What can we do in healthcare to build trust, fill the potholes, and restore the relationships amongst ourselves and between us and our patients, families, and communities? Francis Frey says the usual thinking around empathy is that we must walk a mile in another person's shoes. But of course, that is almost impossible to do because I can't really know what it's like to walk in your shoes from where I sit and from my lived experience. The breakthrough in empathy, Frey says, is the concept of centering someone else, putting someone else at the center, choosing to spend time with another person and getting genuinely curious about what their experience is and has been. I can't walk in your shoes, but I can put you in the center, and I can learn about your experiences by getting curious. The second component was logic. I won't trust what I can't understand. It's hard to believe in someone whose judgment you believe to be suspect, whose ability you doubt, and who you don't feel you can connect to and communicate with. We believe in people who show us that they are capable. But capability without communication doesn't work either. To solve for this, Frey says shoulders, eyes, and question marks, by which she means sit down, make eye contact, put aside your distractions, ask questions, and this is important, care about the answer. Ask questions and care about the answer. That's how to communicate when you want to build trust. The last dimension, and my favorite, is authenticity. You cannot be good at being anyone but yourself, and it's hard to trust someone who isn't their authentic self. Without you being authentically you, trust will weaken. Skepticism about intentions and motivations will creep in. Here's a simple diagnostic test. If your work persona and your home persona are different personas, the authenticity part of the trust triangle is probably weaker than it could be. In survey after survey, what people want from leaders is follow-through. Tell people where you're going, take them there, and then tell them where you've taken them. Trust isn't built overnight. You've got to listen, really understand, act on what you're hearing, share how you are acting, and then do that over and over and over again. And perhaps after the 10th time of doing that, people will begin to trust that you mean what you say and you say what you mean. As I studied trust, I came across this one unusual story that stuck with me for some reason for days afterwards. I want to tell you the story. The story was of a woman who was driving her car down a backcountry road in Australia. She came to a turn in the road where her son had been killed tragically in a car accident some years earlier. The memory triggered an immediate panic attack for her. She pulled her car over and she couldn't drive onwards. She picked up her phone in that moment and she dialed. Not her husband, not a close friend, maybe that was a good thing, I don't know. Not her husband, not a close friend, not the police, nor an ambulance, but the National Roadways and Motorists Association. The NRMA dispatched someone to come see her, and that person got to her within a few minutes. And then the NRMA worker did something remarkable. He sat with her in the car for the next 2 hours, holding her hand, listening to music that reminded her of her son, talking to her to ease her panic until she was able to safely get on her way. She didn't have to get her car towed. She didn't need to go to the emergency room. She didn't need a pill for her panic. She just needed someone to take the time to be there with her. Sure, there might have been a quicker way, but this would have led to expensive, wasteful, inexpedient solutions instead of getting her what she needed most to help her heal. And when she was asked why she had called the Motorists Association instead of family or friends, she said simply, because I knew they would come and I knew they would listen. That's empathy at a whole organizational level. That's a logical service. That's the consistency of authenticity. That's giving someone exactly what they need, when and how they need it. That's trust. The presence of trust can create successful improvements in healthcare, but its absence is absolutely toxic to improvement. In the early days of the pandemic, Barts Health in Northeast London, like many other health systems, faced crushing pressure on its emergency department, its ICUs, and the hospital as a whole. To ease that pressure and provide alternatives to patients who needed help, Barts partnered with the London Ambulance Service to help launch a program called the Barts Emergency Access Community Hub, BEACH for short. The program would redirect emergency callers to a service that would provide alternative care options, including video visits, scheduling for same-day or next-day appointments, or simply receiving advice and reassurance over the phone. And despite being modeled after successful evidence-based community emergency medicine programs, the program struggled because it had failed to develop a clear vision, local buy-in, and a shared sense of purpose and ownership. In short, BARTS, unfortunately, had failed to generate the trust needed between the key stakeholders. After 10 months of trying to make it work, the program shut down, and the partners walked away from the table. But the project's co-creators, the inspiring co-creators, Joanna Moore, Tiffany Wishart, and Tony Joy, were not dissuaded. They knew the model would work if they could just figure out how to keep the parties at the table. And so they set about working through the relationships. They held listening exercises, co-production meetings with all of the stakeholders. They worked through data transparency and ownership issues and ensured everyone felt their roles were valued and that they were respected. Joanna asked every stakeholder to articulate their vision for the project in 10 words. This is an interesting exercise. Articulate your vision for the project in 10 words, and then describe how that mission mattered to each of them personally. It's an important riff on the what matters to you concept that Maureen Bizignano and many others have helped us understand as a powerful way of engaging our patients in co-producing their care. It turns out, perhaps unsurprisingly, that asking what matters to key stakeholders in a novel improvement program can build trust and relationship in our improvement efforts as well. In the end, they relaunched the service as the REACH program. And having built trust and relationship, the program has soared. All parties in and enthusiastic, the detractors now allies, and the results are pouring in. Within 6 months, 60% of nearly 3,500 emergency calls have avoided the ED altogether, receiving advice over the phone, care at home, or care in their GP's offices. The service is already cost neutral. It has unburdened the ED, allayed waiting times, reduced the greenhouse gas impact of the system, and increased meaning and joy for the team members at BARTS and at the London Ambulance Service. And all of that is wonderful and amazing, but the most striking thing about this story is how fast the turnaround happened. From initial failure to relaunch of REACH took just 11 weeks. To be clear, Joanna reminded me, this was a very tough 11 weeks. The trust today is still being built with every interaction that the service members have. But this razor-sharp focus on trust has righted the ship in record time. So often we wonder why our evidence-based interventions don't succeed or can't be scaled or can't be replicated. I submit to you that at least one reason, if not the main reason, why our initiatives succeed or fail is whether we've invested the time up front before the initiative is launched to build a set of trusting relationships. But friends, we're going to need more than trust to restore our systems and end moral injury. If we are to have a different future in healthcare, we need the courage to ask new and different questions, courage to dig deep into the foundations of how our health systems are built and have us face the hard facts, courage to acknowledge histories that we may not have caused ourselves, but that are still being enacted today, courage to face the resistance that we will inevitably face. In the past few years, we have seen many stories of courage by our colleagues and peers. Often these are framed as stories of healthcare heroism and lauded by the media and the public. To be sure, each of us in our own way has shown immense bravery during the past 2 years of the pandemic. We will need all of that courage, all of that bravery, and even more to face these important challenges that lie ahead. When I was a resident at the Brigham and Women's Hospital in Boston, there was a long-held suspicion that patients of different racial backgrounds who came in with the same presenting signs and symptoms of heart failure would be admitted to different clinical cardiology services. In 2015, the residents at the Brigham looked back at 10 years of data from the cardiology service, and they confirmed that indeed Black and Hispanic patients admitted with heart failure, the hospital's most common admitting diagnosis at the time, were less likely to end up on the cardiology service than their white patient counterparts. Those white patients went on to have better care outcomes and a better care experience. The inequality in outcome remained even after controlling for other factors such as socioeconomic status, insurance status, comorbidities, and more. My clinical colleagues at the Brigham took immediate action and were met with immediate resistance. You see, the hospital was not yet ready to admit unconscious bias and racism as a driver of these discrepancies, nor was it ready to adopt race-explicit solutions, despite the evidence that so-called colorblind policies had done little to close these unjust gaps. The hospital didn't have the courage yet to face the hard facts, but their clinicians did. They didn't look away from the potholes or the fallen trees. They faced them head on. And they determined that they couldn't just fill in the potholes and pave over the problem, but they needed something bolder to change the conditions, to create new roads altogether. They needed what they called an anti-racist agenda in healthcare. My colleagues, Drs. Michelle Morris and Bram Wispelwey, were two of the clinicians involved in the study. They developed a race-explicit approach to addressing harms like the ones they found at the Brigham and published an anti-racist agenda for medicine in the Boston Review. Their plan built off of scholarship on applied justice to describe an approach that was as pragmatic and restorative as it was courageous. Morse and Wispelwey used a reparations framework to craft what they called the healing arc: acknowledgement, redress, and closure, to help correct the wrongs they found in the cardiology service. First, the hospital would acknowledge the bias openly with the community, conduct community engagement councils to explain the findings and listen to the responses, and offer a space to discuss and co-produce a path forward. Second, the hospital would offer redress, a direct solution to end the health inequities that it was perpetrating and try and offer some restitution, some payback for the past injustice. At the Brigham, this meant that rather than relying on provider discretion and bias or patient self-advocacy for where to admit the patients, the hospital would take steps to add pathways and order sets to their electronic health records that would allow all patients with heart failure symptoms to default to the cardiology service automatically. Last, the institution would seek closure with the Black and Latino communities affected to determine if the redress actions were adequate. Conservative right-wing news outlets seized on the article and the hospital's planned response and accused both the hospital and Drs. Morse and Wispelwey of racism against white people. And in January of this year, just a few months ago, a group of neo-Nazis marched outside the Brigham, holding up a banner that said, "B&W Hospital kills whites." They handed out flyers with names and pictures of Drs. Morse and Wispelwey that claimed the doctors were promoting an anti-white genocidal policy. Threats were made. Threats of violence and scorn were heard. We can easily see in this story the courage of Michelle and Bram and their colleagues and their peers. But I think courage is foundational to the institutional response as well. Each step in the healing arc is critical. Each step requires courage at both the individual and at the institutional level. Courage to admit a mistake and ask the hard questions about how it happened. Courage to take the needed actions to not only respond, but to do so in a way that pays back current and past debts. And courage to face a community that has been harmed and ask for closure. These moments of acknowledgement, redress, and closure need not occur on such grand scales. You and I can practice these acts in our efforts every day. I remember some years ago I had a patient who had been waiting for an MRI in a hospital for 3 days, just sitting in the hospital, waiting. I'd just come onto the service, and in our first meeting, first time I ever met the gentleman, my patient and his wife began screaming at me. I suppose I could have walked right back out of the room and got defensive, but after gathering myself for a moment, I realized that my patient and I were on the same side of this. that we wanted the same thing. So I did what Francis Frey would probably have coached me to do. Shoulders, eyes, question marks. Trust. I sat down, faced them both, and asked questions. Listened, and I cared about the answers that they gave me, even as they seethed with anger and rage. And then I acknowledged the harm we had perpetrated, even though I was just meeting them for the first time. And then we built a solution, redress. His wife would accompany me right then downstairs to the sub-basement of the hospital where the radiology schedulers lived. We took the elevator down, and the scheduler was shocked to see an actual family member screaming at them to get it scheduled. The study was scheduled within hours, and my patient went home that day. He got what he needed, and I fulfilled my commitments to heal. Closure. This is my hope for us today, that we seek out these moments of contradiction, where the potholes and fallen trees obstruct the road ahead, where the systems that prevail prevent us from realizing our duties to heal. And then instead of suffering under the weight of the moral distress, we call the potholes as we see them. We don't turn away. We hold our patients' hands if that's what they need. We face the hard facts even if our systems aren't ready. We create allyship with our patients even when they are angry. We do what is needed to fix the potholes. And the only way we can do that for the long haul is tillsammans, together, in relationships grounded in trust. The road to regeneration of our professional calling is a long one. Our health systems did not get to where they are overnight, but neither did they get there by accident. At IHI, we have a saying that many of you know: every system is perfectly designed to get the results it gets. If we want a different result, we must change the system. And the only people capable of restoring trust to our systems and creating these courageous healing arcs are us. 2 months ago at the IHI Leadership Alliance meeting, Dr. Navneet Marwaha, the Chief Quality Officer from Northern Light Health in Maine, got up and, noting the long road ahead of us, said, "Just remember that you are entirely up to you." By the end of our 2 days together, everyone was quoting this moment from Navneet. And as with all good IHI meetings, we had added something. You are entirely up to you, and we are entirely up to us. Tak, enjoy this wonderful forum, and I look forward to seeing all of you throughout Gothenburg and throughout our day together here today. Thank you. Tak.